Hello, my name is Dr. Brian Raid, and I'm a naturopathic doctor, and this is a video about when to consider working with a biofilm disruptor in cases of small intestine bacterial overgrowth, also known as SIBO or SIBO. When it comes to treating SIBO, I've treated over 1,500 cases to date in practice. That was my tally a couple of years ago when I looked, because I was lecturing about SIBO and just looked in our, we do in-house SIBO breath testing, and so we looked at the numbers, and it was about 1,500 about 2 years ago. So quite a few cases of SIBO to date. And what I have found is that probably about 75–80% of the time, the SIBO cases that I've worked with, they resolve in a fairly efficient, methodical kind of manner. We identify the type of SIBO, we work with the appropriate antimicrobial agents, oftentimes herbs in my practice, because patients in beautiful Nova Scotia have an incredibly difficult time accessing antibiotics for treating SIBO, because they're a little bit of a niche type of antibiotic. But thankfully, the non-pharmaceutical antimicrobials seem to work incredibly well in my practice for the majority of patients that I've seen, at least. So between antimicrobials, the appropriate type of diet, which can vary a little bit from patient to patient, that will typically knock out about 75–80% of the SIBO cases that I've seen. With the remaining 20–25% of cases, we have to troubleshoot things, and there's not a laundry list, but a notable list of interventions that we sometimes need to look into to troubleshoot those 20–25% of cases. But one of the items on that list, is looking at the possibility of biofilms in the gut. Biofilms are basically a proteinaceous polysaccharide compound that's created by bacteria in the gut, and it essentially creates this layer of really tenacious slime, or another way to look at it is it's kind of like really, really tough soap scum, like you see on a shower wall, in patches lining the intestinal tract. And the microbes, to my understanding, the bacteria, the SIBO bacteria, can potentially hide out behind those biofilms. And those biofilms being so tenacious, it's very difficult for the immune system molecules in the gut to get behind the biofilms. And it's also very difficult / impossible, to my understanding, for a lot of agents to actually penetrate beyond the biofilm, whether they're herbal or pharmaceutical in nature. So the biofilms are kind of like this reservoir for SIBO, where they can kind of go out into hiding. And so the way that it seems to play out in clinical practice, at least, is that when we're working with the antimicrobials, working with the diet, it's helping to kill off SIBO bacteria that are out in the open, but they seem to be able to hide out behind those biofilms and escape complete eradication in some cases. And in my experience, I've had many patients in that 20–25% category, or that group rather, where they are doing notably better, and notably is a relative term. They might be, only say 30% better. They might be 80% better, but they're definitely better. But they hit a plateau. And if they hit a plateau, and even though we're keeping up the diet, we're keeping up the antimicrobials, maybe even switching up the antimicrobials just to see if that might shake things up a bit more, get them over that plateau. If they're plateaued despite those efforts, in my experience, many of those cases will need a biofilm disruptor to get them over that plateau. The idea there being that the biofilm disruptor is going to break down those biofilms, getting rid of the hiding places, kind of scraping the soap scum off the lining of the intestinal tract, and then not when the bacteria don't have any place to hide, then the immune system and the herbs or other antimicrobials can actually kill off those reservoirs of the bacteria, of the SIBO bacteria. When it comes to working with biofilm disruptors, there's different theories out there in terms of when to implement that. Some practitioners implement biofilm disruptors right along with the first phase of their treatment. Sometimes they wait until later. Sometimes I've heard some practitioners talk about starting with biofilm disruptors, just kind of chase everything out into the open and then work with things that way. To my understanding, having poured through the literature, I've taught a course about SIBO to naturopathic students at the Canadian College of Naturopathic Medicine. It was a CE course that was available through that school, and my alma mater. Pardon me. I have not seen any literature actually looking at when is the best time to implement a biofilm disruptor. That literature, to my knowledge, does not exist, and I don't think there are any studies in the works being done on that. So it's really left up to clinical judgment, experience, that type of thing. I'm a really methodical practitioner, so my thought is let's kill off everything out in the open, and then if the patient's not feeling 100%, then let's check our work and see if maybe there's some biofilms kicking around and we might need to chase some microbes out into the open. When it comes to biofilm disruptors, there are different degrees of biofilm disruptor potency. One of my mentors, the mentor to many of us in the naturopathic and functional medicine world, is Paul Anderson. He's an amazing naturopathic doctor from Washington State, and he's lectured about this quite extensively. For any clinicians listening, he wrote a NDNR article about this maybe a year ago, and it summarizes a lot of what he talks about. But it's this concept of phase 1 versus phase 2 biofilm disruptors, and a lot of the agents that we would typically have used historically, like different enzymes or possibly more aromatic type compound containing products like essential oils and things like that. To my understanding, they're good at breaking down phase 1 biofilms, but the phase 2 biofilms, which are really, really tenacious, like super soap scum, they generally require more of a sulfurous component to things in terms of the biofilm disruptors. And so things like DMSA or DMPS can be really important. Also, Dr. Anderson talks about this sort of combination molecule of bismuth and R plus alpha lipoic acid that compounding pharmacies will combine together to create some kind of a special super thiol group containing molecule. And so that's the type of combination formulas we'll work with. You might be thinking like, oh, well, N-acetylcysteine, that's got, cysteine in it, so therefore it's sulfurous. And to my understanding, that's really still more in the phase 1 biofilm disrupting category. So the long and short of it is that the phase 2 biofilm disruptors seem to be pack a lot more punch than the phase 1s in my clinical experience, at least, and they can be really helpful. But with great power comes great responsibility, and when you're using a phase 2 biofilm disruptor, you can really flare someone up if you aren't dosing it appropriately, if you don't build it up fairly methodically, and just really make sure that you're talking to the clinicians here, but really check in with your patients to make sure that they are tolerating it well, and forewarning people that it may be well tolerated for the first 2 to 4 weeks, and then the way I think about it is you're breaking down those biofilms, kind of getting rid of the superficial layers, then getting down to the deeper layers. That can be sometimes when you really start seeing the release of microbes into the lumen of the intestinal tract, and then you can see a big flare up. So it's like, oh, I'm tolerating things for a month, no problem, and then boom, suddenly like I'm flaring like crazy, what's going on? That would be oh wow, you've really been digging deep into those biofilms, and now you seem to be liberating too many critters and need to kind of back off. So it is something that can be a bit of just something as a clinician, I am always mindful with any protocol I recommend, but I'm extra mindful with my biofilm disruptors, both in SIBO patients and Lyme and co-infections and whatnot too. So biofilms can be really important to consider and address in more tenacious or recalcitrant cases of SIBO.